Okay, so it's 7 o'clock and it's the live broadcast with me, Jonathan Stoiano. I've got some questions here tonight. I've got some questions here tonight. And I'm going to go through them one at a time. And
so funny.
So,
does anyone actually watch
we've got. It's going to be much better in a minute because. Right, can you turn that light on over there? The lighting's not right. Freddie, can you turn that light on there, and then can you both leave?
No
right. So I've got quite a long question here. There's a light over there. Can you please tell me how effective a lower back lift with auto back lift with? Okay, thank you. That's enough now. Thank you. With auto augmentation to the buttocks. So this patient, so here we go. Here's the question. Can you please tell me how effective a lower back lift with, goodness for that was stressful, auto augmentation to the buttocks gluteal flap is for improving the overall shape of the buttocks. I've lost over 100 pounds and my backside is completely flat. I have loose, mouse. Loose skin on my back. I've already had a tummy tuck and I work out 5 to 6 times a week and focus on flute exercises, but haven't seen amazing results. Not entirely sure what flute exercises are, but I'm going to gloss over that. So this is something which is not something I've got a huge experience in, to be honest with you. I don't have a major experience of buttock augmentation, and the first thing I'd say is go for an expert because you need someone who does a lot of it. But just in general terms, I can talk about this concept of auto augmentation of the buttocks using a gluteal flap. It's a concept in people who've lost a lot of weight. What you do when you lose a lot of weight is you tighten the skin by removing large areas of skin and fat. And it's often possible to keep some of that skin and fat attached somehow and then turn it round and put it into a place where there is a loss of volume. The common areas in the breasts. So someone who's lost a lot of weight will have droopy breasts, maybe droopy areas of skin on the side. And so you can do a breast lift and take some skin from the side, the lateral part of the breast, and skin and fat from that area and put it into the breast to auto augment the area. So it's using an augmentation of some skin that you would normally have thrown away, but you can use it to augment the buttocks. It has got risks. It's got risks because that skin has got to be taken. You don't actually take the skin, it's mainly the fat really. It's taken and moved into the buttock, and whenever you're moving tissue around, there's risks that it might be cut off by its blood supply and it might not all survive, so you can get areas of what's called fat necrosis, little hard lumps and things, if not all of that fat survives by being pushed into the buttock. But it is a way of augmenting your tissues by using your own tissues without having to use an implant. So it's a good thing to do. It's not a particularly easy operation to do, and it's something which has got risks and complications, which I'm sure your surgeon will talk to you about as any buttock augmentation. But the concept is sound, and I'm not the best person to answer the question because it's not really something that I have huge experience of, but I would say the concept is sound. Look for, as long as your surgeon is confident with the procedure and can demonstrate good results and has taught you through the pros and cons and you think it's a good thing to you, then it's something that you should consider. Not a very good first one. I'm sorry about the hubbub. Oh dear. Oh, look at that. We've got some. Hello. Oh, Rachel, you've emailed me, haven't you? And I responded. Oh, God, that's awkward now that I've seen that because I don't know if I've responded. Oh, that's awkward. I will respond tonight, hopefully after this. Sorry. Special. Oh, God, special guests. Yeah, right. Not very special. Well, they are very special. Shouldn't say that, but not really. Sorry. Anyway. you. Hi, Denise. Nice to see you. So there we go, and we've got a question here from from a patient who is she's not a patient, it's a patient person saying breast reconstruction with implants or expander. Watched earlier. Interesting to see your thoughts. After having my implant taken out on July the 17th due to pain caused by the radio and now pain-free down to steroid injections and acupuncture. Fantastic. Thought I was going to have it put back in, but got told on Tuesday I have to go have an expander put in first. Then hopefully BodyTite end of January. Didn't know if that was your thing to talk about. Yeah, it is my thing to talk about. This is a breast reconstruction question, and this is a problem. And what I would say is breast reconstruction is different to breast augmentation. Often implants are used, and you might think that it's a sort of similar thing, but it's not. It's a different entity altogether. It's got much higher risks, complications, and it's, broadly speaking, much more difficult. And my thoughts about this are that at the end of the day, with breast reconstruction, you've got to work with your surgeon, work closely with your surgeon and get a plan, because there's pros and cons with anything. And sometimes it's difficult getting other people's opinions because they might conflict with the opinions of your surgeon or someone that you trust. And then you might think, what's right? There's no right or wrong. But I would say that my thought about this is you've had obviously had a mastectomy, and you've had radiotherapy, which has been extensive because it's caused you a lot of pain. You've had to have the implant removed due to the pain. And you've had steroid injections, acupuncture, and this is the problem with implant-only reconstruction. When you do an implant-only reconstruction for breast reconstruction, it's a totally different thing to a cosmetic augmentation. Sometimes people think, oh, great, I'm going to get breast implants. It's totally different to cosmetic augmentation. A cosmetic augmentation is a situation where you have a breast and you're enhancing that breast with an implant. You put the implant behind the breast, whether it's in front or behind the muscle, it's always behind the breast, and it's enhancing that breast. So everything that you feel is breast tissue, and the implant is just enhancing the natural breast. When you do a breast implant for reconstruction, it's totally different. There's no breast. So all there is skin. You always put it behind the muscle. So you try and cover the implant with muscle. But there's just skin there, and it is what it is. It's an implant and skin, so it looks completely different. There's no natural movement, there's no natural droop to the breast. It's really, and this is my experience and my view, it's really good for smaller breasts. I would say something around a B cup. It depends on the width of your frame as to how big an implant you can use, but you can't reconstruct a very big breast with just an implant. And it does have limitations, particularly in terms of the other side, because the other side, your natural breast, will move, and when you take your bra off, it will sit lower and it'll have a natural move and a natural flow to it, whereas the reconstructed breast will not move. It might fill the bra in terms of in clothes, it might be a good thing, but out of clothes, it will never have great symmetry with a natural breast. And I'd be concerned that you've had radiotherapy. Now, radiotherapy is a relative contraindication to having an implant-only reconstruction, because radiotherapy damages your skin. It zaps the area and it kills all the cancer cells, and it's fantastic at killing any residual cancer cells that's going to be there, but it will also damage your skin, and it will scar your skin. Not only scarring in terms of what you can see, but deep scarring, and it makes the tissues very woody, very firm, and it makes it move even less. Because it scars everything, there's a very high rate of capsular contracture hardening around the implant. That can happen with anyone. It happens in people with cosmetic implants, cosmetic augmentation, but it's an even higher risk in someone who's having a breast reconstruction who's had radiotherapy. There's an extremely high risk of getting a capsular contracture, scar tissue forming around that implant. And so it's a relative contraindication. It's not a great way to reconstruct the breast that has had radiotherapy. And so I would be concerned about the fact that you've got pain, you've had to have your implant removed, and now you're going down the road of having another implant. Because I would say, look, that's going to get pain again, isn't it? And that's going to potentially go hard, and it's not a fantastic option for reconstruction in someone. Oh man, I get this every time. A battery for someone who is having a breast reconstruction. Also, the question is about having an expander put in first. Yeah, that's standard, because what happens when you have the implant removed, all the skin recoils. Not only the fact that radiotherapy there, but in a normal patient, the skin recoils. And because there's no give in the skin, it's very hard to get a fixed volume implant back in. And so it's very common to have to put an expander back in. As I say, you often need to get total muscle coverage when you use an implant for reconstruction, completely different to a breast cosmetic augmentation. When you're putting cosmetic implants in, you only put the implant under the pec major. A lot of people say, oh, I fancy a dual plane. Dual plane means half of it's pec major, half of it's on under the skin. They're all dual plane. There's different levels of the dual plane, which is something you can talk about. But all implants in a cosmetic patient are just under the pec major. The pec major is a muscle that goes across here. This part of the implant is always is not covered by muscle. When you're doing a reconstruction, you want to get all of the implant covered by muscle. So you often raise up the serratus anterior, other muscles in the area, basically the rectus, to get complete muscle coverage over the implant. And because you're trying to get complete muscle coverage over the implant, the muscle doesn't give as much as the skin. And so you often have to put an expander in a flat implant and then blow it up gradually. In order to give you get a good volume of implant in. So it's completely normal to go expander first, but I've got to say and then B-lights, yeah, fine. B-lights are silicone implants, very high risk of capsular contracture with silicone implants in patients who've had a breast reconstruction for a breast mastectomy followed by radiotherapy. So that would be my concern, but obviously you're working with a surgeon, whether you're a plastic surgeon or a general surgeon trained in plastic techniques. So a breast reconstructive surgeon. But yeah, that would be my concern. But anyway, all the best with it, and as long as you've talked about all this stuff, then good luck with everything. But it's a normal thing to go be expander first, then implants. So I hope that's answered that question. So I did it. So we've got here Zoe, good evening. Shirley, hi. Shirley, good to see you all. PC's in battery saver mode. Is it me or does that happen every week? Because I'm on the PC, because my webcam's not working properly on my big computer there. So there we go. There you go. What we got now is a question which says they have left these notes. Okay. I was looking for an uplift and reduced size. I believe I may need implants for this. I'm not 100% sure. I was wondering the cost. The cost and payment plan. Okay, we can talk about that. The cost and all these questions, by the way, when people ask a question, I do answer it. We answer the question to the person, and then I say, oh, I'm going to talk about it on Facebook Live so we can elaborate on things. So I think we've probably told you, I hope we told you about the cost and things. But yeah, uplift and reduced size, I may need implants. The reason I wanted to talk about this question was because I don't think you will need implants. It's a really interesting concept, this. But broadly speaking, I say that in terms of the shape of the breast, that's an uplift. That makes the shape better. In terms of the size of the breast, implants are very good at making the size better or bigger. Because not necessarily better, but size bigger. That's the really good thing about implants. They make it big. They make your breast bigger. So on the face of it, if you're saying uplift and reduced size, then that's a breast reduction. An uplift and reducing the size is a breast reduction. A breast reduction, an uplift is part of it. An uplift is part and parcel of a breast reduction. So a breast reduction where you is where you do a lift and reduce the size. So on the face of your question, you need a breast reduction, and not even on the face of it. I think the breast reduction is probably the right operation for you. It's interesting though that you say I think I might need implants. I think it might be that you just think breast surgery equals implants, because sometimes people think just implants is the way to go for all breast surgery. But it might be that sometimes people do talk about implants in terms of giving fullness in the upper part of the breast, because if you have a breast reduction, they're often quite full, your breasts, but then they settle and you get a sort of concavity in your upper pole. And some people say, oh, I want it to be fuller in the upper pole. And if you have it fuller in the upper pole, well, then that is a something that you get with implants. So implants do make it fuller in the upper pole, but I wouldn't do this reduction sort of plus minus technique. You do a reduction and then put an implant in order to get stable fullness in the upper pole. People do it, and it is a thing. But I think it just runs extra risks because you're using implants, which have come with risks and potential for complications. So I think if you are unhappy with the size, it's a lift. If you're unhappy with the shape, if you want them bigger, it's implants. If you want them smaller, it's a reduction. And as I say, a reduction is part of a reduction is part of the sorry, a mastopexy is part of the lift. So I hope that's helpful. Denise, you did miss me talking about the back lift with auto augmentation to the buttocks. That was first up. I don't know how well I answered the question, Denise, but basically I said that I'm not that big man in terms of buttocks, and so you really need someone who's good at doing buttocks. But it's not a unreasonable thing to suggest, and there'll be a you can get this again on Facebook. Basically, if you go on the page, I think afterwards you can just play it again, and it was at the beginning, the Denise thing. I think what we'll also do, Denise, is what we do is we chunk things up and we put them on YouTube. So we chunk the questions up so you can just find answers to single questions. And then when people have asked a question, we send them just the specific answer to their question. So you don't have to trail through it all, but you don't have to trail through it all for that one because that's right at the beginning. Yeah. Excellent. Thanks, Denise. Yeah, sorry, this is you don't know if you can see what Denise is saying. So that's it. Yeah. So Denise, have uploaded this video on the groups so you can replay it. Look at you. Woo! Look at this, Rachel. So what we got? Have you got? Oh, we haven't got the jamboree at the beginning. Yeah, a bit of a jamboree at the beginning, but steady now, steady. Now we're on to this question here, which says, I had a tummy tuck and muscle repair on the 27th or whenever this year. I was told by my surgeon I did not need lipo. I am very unhappy with my results. I have a very high scar and a bulge all the way across and feel that not enough skin was removed, as I still have rolls when I sit, and if I lean forward, it still hangs. I went to see my surgeon when she was in England 3 months after the operation, and she said that she could do BodyTite lipo and it would make it okay. But I need to wait for 12 months first. I want to get a second opinion from another surgeon, and my friend has recommended I message you to see if you can help. Boom. That's what we're talking about. That's the sort of publicity we need. Excellent. Thank you. I hope I can help, and I have answered this question to you personally, but I will answer it in real life now. Yeah, okay. I think there's some good things here. So I think it's tough. It's a tough thing to do, surgery. And when you're doing a tummy tuck, I haven't seen photos and things. You have to look at before and after and things. But to be honest, I don't really need to see photos because I was just talking in general terms anyway. When you have a tummy tuck, when you're doing the surgery of a tummy tuck, everyone wants to give obviously fantastic results, and you are trying to remove as much skin and fat as possible to make it as tight as possible to give you a great result. And when you have a tummy tuck, you often can't walk straight. In fact, when you do the surgery, if you saw the surgery, you can't do the surgery. You can't close the abdomen. When you take off the bit of skin and fat that you're taking off when you're with the tummy tuck, the patient's lying flat on the table, you couldn't close the wound. You wouldn't be able to stitch up the patient without doing what we call breaking the table, which means sitting you up and putting your flexing your hips, so putting you in a sort of fetal position on the operating table in order to take the tension off so that we can close it. So it's really tight to close. And so when you often have the surgery, you can't walk straight and what have you. So for that reason, one of the not for that reason, well, yeah, for that reason, one of the risks of the surgery is wounds opening up, because when you're training as a surgeon, there's all this like tension-free closure, and you're not supposed to close wounds under tension. But as plastic surgeons, especially as cosmetic surgeons, a lot of the work we're doing is tightening the skin, and so we're often actually closing the wound under tension. Now, there's lots of things we do to take the tension off the skin, but the bottom line is it's under tension, and there are risks. There are risks that the wounds won't heal up properly, and there's a risk of what we call wound dehiscence, the wound opening up, and something we worry about. Can be quite impressive, the wound dehiscence after a tummy tuck. So it's always a worry. On the one hand, you're worried about taking away too much, making it too tight, and the wound pinging open, and then that patient getting a wound and having dressings, and they've come for a cosmetic tummy tuck, and it's a disaster because they've got dressings in their tummy, and it's really not what they wanted, and it's not a good thing. So that's one end of the spectrum. Now, the other end of the spectrum is you don't take away enough, and you still got a roll. Which sounds like sort of where you are, really. You've still got a roll, and you're not happy, and it's not a good result. Obviously, you want to make it perfect for everybody. I guess out of the two, you're probably better off having a bit of a roll than having the wound breakdown. But it's nevertheless, it's an unfavorable or an unhappy result, which is something that no one ever wants. But that is something that you've got. But your surgeon has engaged with you and has offered you a solution. So one thing I would say to you is, you sometimes see people who say, "Look, when I bend forward, I got this big bulge, and when I lean forward, it's still there." And it's normal to have you've got to have a bit of flexibility in your body. If you bent forward and there wasn't a bit of a bulge there, you wouldn't be able to stand straight. So there's got to be a bit of a flexibility. Everybody when they bend forwards has more of a bulge than when they straighten up, because the body hinges. So there has got to be a bit of something there. So if it just looks like that when you're bending forward, and it looks okay when you're sort of standing straight, that might be not as bad as if it was sort of a big roll there all the time. What that your surgeon has I was going to say the high scar. So your surgeon has talked about BodyTite lipo, which is great, and she's also said that you wait for 12 months, which is reasonable. I think waiting 12 months is a reasonable thing to do. And I think BodyTite lipo is a reasonable thing to do. BodyTite lipo is a liposuction, and it's a assisted form of liposuction. I've spoken before about different types of liposuction. That's a radio frequency assisted type of liposuction. And it may be the liposuction will be enough. Liposuction doesn't remove skin, but it might not be that you need any more skin removal. It might be just having some of the fat removed will help to give you a better shape in that area. And sometimes you need revisions, and your surgeon has offered you one, and that's really good. So I don't think it's as well. I hope it's not a disaster. You're very unhappy with it. I hope you can become happy with it with some liposuction. But I think that it is it is difficult. All this surgery is difficult, and sometimes it doesn't work out right, and you have to do bits and bobs to try and make it better, and your surgeon is trying to make it better. We're not trying to give you a result where you've got bulges and you're unhappy. We're trying to give you the best result. And we're always, thinking, don't want to take too much, don't want to make it fall apart, don't want to take too little and give you a bulge. It's the nature of the beast. It's not a precise science. And the main thing is how you look after. This is what I found. The main thing is how you look after people afterwards. And I think that's the difference between a happy and an unhappy patient, to be honest with you. Well, maybe not that's the difference, but that's a difference. And sometimes people really don't get very well looked after afterwards. And I think that's a source of great unhappiness if you've got an unfavorable result and you are not looked after. We are all at risk of getting problems and complications and what have you, but it's how we handle those complications. It's how we look after people. And so that's the main thing. you also mentioned a high scar. High scar makes me think it's a bit slightly odd that you got a high scar. High scar is usually occurs when paradoxically in people who don't have a much don't have a much fullness. So people who it's very tight, people who don't have a huge apron to remove. So it doesn't really go with you having residual fullness, because residual fullness suggests to me that you might have had a large apron to be removed. I might not, I might be wrong, but people who've maybe just had a couple of pregnancies and just got a little bit of fullness in their tummy and they're borderline, is it a full tummy tuck, is it a mini tummy tuck, can you get away with a full? It's going to be really tight if you do a full. And those are the patients who the scar can tend to ride up and be quite high, because it's much tighter, and because you usually make the top incision above the belly button for a full tummy tuck. And so if you can't remove much skin, then you might have to increase the height of your lower incision, and that gives you a higher scar, which people don't like. So the number one thing is to wait. And I think you said you had your surgery in June. 5 months. 5 months is still not, I think they're still settling to go. I show photos in my slideshow of the patient at 8 months. Scar's still a little bit high, scar's still a little bit red. And then, you know what? I can show you that photo with this. And then at 16 months, it settles. I think I can anyway. I mean, I'm on new territory. Oh, have I done something? Did I go then? Oh, I'm on new territory here, but I think I can show you that on this. Perhaps I should practice this before I try it live. On my live, I am live. Anyway, in for a penny. Let's just go for it. I don't know what's going on with this thing, but I'm going to go for it, and I'm going to show you this photo of a patient of mine who has still got quite a high scar at 8 months. Here we go. Here goes. So let's do that. And oh no, let's not do that. So we're on that tummy tucks thing. What I'm going to do, share. Oh, I need to add the extension on Chrome. Okay. Maybe I won't do that now, people. Add to Chrome. Oh, right, okay. I can't do it. Or maybe I'll do it in a minute. Here we go. I've done it. Share. Awesome. Share screen. So there you go. Am I sharing my screen? What I want to do is I want to do that. So this patient here, 8 months post-op, scar still quite red, still quite raised. 16 months post-op. I think he's put on a bit of weight, but that's another story. But the scars dropped down and settled. So it doesn't always take 16 months, but at 8 months, if it's still red and pulled up, you'd be cheesed off thinking this is how it's going to be forever. So it can take a long time, basically. As I say, well, it doesn't always take that long, but it can take a long time. Did that work? Did that work? I thought I showed my. Can't see it. Did that not work? No. Can't see it. You didn't see it then? Did you not see my screen? Bring a guest. I can bring a guest. Share your desktop screen. Share. Application window. Try that. Share. You see that? There. You see that? 8 months, scar a bit red, bit raised. 16 months settled, put on a bit of weight, and all the other things I said before. How's that? How's that? Just like that. Has that worked? Anyway. Oh, sorry. That's someone else. It's all gone. It's all kicking off now. Did that work? I wanted to congratulate you. You're very good. Thank you. Did that? You say I'm very good, but I don't know if that worked. Anyway, no, it didn't work. Okay. You know what? Cutting edge. This is, you're seeing it, guys. You're seeing the cutting edge of technology here. And Oh, you know what? Maybe I need to. I got an idea. Oh, you're not doing anything tonight, are you guys? You're not doing, I'm going to put that. That's in the lobby. You see, it's in the lobby. I'm going to just bear with me for a couple of minutes. I'm going to. Okay. I've got to read the instructions, guys, quite frankly, because I haven't read the instructions and I make a comment and attach. No, it says. No. Anyway. Ooh, ooh, right. This here. Now. Huh? Who said they couldn't do it, guys? Who said you can see it? Can you? Can you see it? Can you see it? Oh. Can you see it? That's the one. Oh, that's not there. 8 months, 16 months, scar fade, scar red, bit raised, 16 months settled and dropped and put on a bit of weight. Huh? Did that work? That worked, surely to goodness. Surely to goodness that worked. Did that work? Anyway, I don't know. I don't know what's going on. I need another. Yes, you saw it. Did you see it? Did you see that guy? And it was a bit red and raised at 8 months. That was well worth the wait. I'm sure you'll agree. So it's not usual to have to wait, that long, but sometimes it can be a bit red, and red and high at 8, at several months. So you're 5 months in, and so that's not unusual. Oh, you know what? I know what I should have done. Anyway, I think I should have done this. Oh no. Okay. Just memo to self, practice the software before you do it live. Okay. Was a bit small, was it? Okay. Right. Well, yeah. I think I needed to. I think I've got an idea of what I'm supposed to do, but so where were there? Where were we on that question? So yeah, that was this high scar, and the fact that it still bulges and your surgeon's doing a revision, so that's fantastic. So hopefully that's going to be okay, and I hope you're going to be okay with that. We've got it all going on here. I think people saying that they can't see the thing. Make a comment. He's ditched us. Oh, he's ditched us. No, I didn't ditch you. I was just doing the technology. Rachel, excellent question. Rachel, you are a question master general. You really are. What can be done to lower a scar? Oh, very good question. Not easy. High scar is difficult to treat. So first thing I would say, the one step before that. So if you have someone who has got a minimal fullness in their abdomen and it's going to be tight, well, one thing you can consider is a mini tummy tuck rather than a full tummy tuck. So no scar around the belly button, just taking a little bit above the pubic area. That's one option. The other option you can consider, if as a surgeon, if you have someone who's going to be very tight, is putting a T into the scar. I'm not sure if I can explain exactly how that works, but if you are not going to get it's quite important to make the scar low, obviously, because you want to have it in the bikini. So you can make the low scar low, make the high scar above the belly button. But then if you can't get it all the way down, we need to see the surgery, because what you do is you split the bit of skin up the middle, and it ends up with 2 bits, and then you can close a little bit of it as a straight line. So where the belly button used to be will close as a vertical portion of the scar to get a short little T in the middle. I'm not sure if I can explain that well, but it gives you a little T-shaped scar rather than just the one scar. I don't like that scar. It's got a high risk of breakdown because it's a T, and anytime you have a T, there's an increased risk of breakdown. But you could argue you got more of a risk of breakdown if you try and take the skin all the way down, so you're taking the tension off it. And you could also argue you could later on cut that T out. Not sure if I explained that very well, but that's one option if you have got someone who's very tight. But if you, in answer to your specific question, is what can be done to lower a scar, it is difficult, number one, but it's not impossible, and you can lower a scar. So when you you have to let it settle, you have to give it time. That one settled took 16 months to settle. I'd say at least a year, and this patient's waiting a year. So 3-6 months things really start to settle, but really 12 months is probably the best for letting scars settle and what have you. And then if it is still high, you can lower it. And what you do as a surgeon is you cut a little bit above it. So you cut the scar out. So you cut above it, and then you cut a piece of tissue below it. So the reverse of what you're doing for an abdominoplasty, where you're taking a bit going up north towards the umbo, you take some down south and you bring that scar down. The scar tends to level up a bit because you can't undermine too far, because it's, you've got the pubic area there and you've got the thighs, so you can't undermine as much as you can when you're doing a tummy tuck, because you can undermine very widely up the top. So if you're undermining widely up the top, that piece of skin is very mobile and the other piece of skin is static, which is why the scar moves to where the lower incision is rather than going halfway between the two. So when you lower a scar, you don't undermine anything going up because you don't want the scar to go up again. You undermine going down, going south, and try and pull that scar down. I'm not sure if I explained that, but anyway, it's difficult. It's difficult to lower a scar, but it's not impossible. But it does mean a whole fresh scar, and just undermining down and pulling it down, taking some more skin out. Oh, it worked, but you could hardly see the photos. It was a bit small, too small, very small. That's what you call a mini tummy tuck, Jonathan. Can I ask you a question? Oh my Lord, here we go. Big question there. Hope I'm posting my questions. Yes, you are, Vicky. Oh my God, it's all kicked off since I did that thing. Was it a bit small, guys? Was it a bit small? I mean, I'm not saying that I don't know when to give in, but I'm just going to have, I think I know what I'm doing. Application window, share. That's what I do, number one. That's exhibit A. Okay. Exhibit B, that goes like that. Exhibit C, that goes like, no, sort of. Yep, that goes like that. And then, my friends, what we do is we do that. And I think you will agree that actually what I can do is I can do it. Where's the, here we go. Present what? Oh. Yep. Oh man. Anyway, I think that's big. Is that big? Oh no, that's got me back, isn't it? Oh goodness me. Was that? You know what? My battery. Oh, sorry. Excuse me. I just got to get my bat. Actually, I can carry my. I'm going to carry it. Just get my battery. So anyway, that's how you do that. Lowering scars, and that is. I'm going to show that adequately. Endeavour to make that better in the future. Right. Oi, 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 oi. Oi, oi. Right. Oh, right. Oh, right then. Yeah, sorry about that. Charging. So, can I? Yes, Roby, you can ask me a question, and Vicky has asked me a question. It was better. Was it better? Okay. Oh, Junie's asked me a question, and Sarah's messaged me a question. Wow, crikey, this is It's Questionsville, Tennessee. Right then. So what we got? Roby. Yes, you can ask me a question. So Roby, you can ask me a question. I think you can go live on here, or not live, but here we go. Look what Vicky's done. Vicky's done a massive one here. Hello. I hope I'm posting my questions in the correct place. By the way, Sarah, I will check your question if you've messaged me. I will check. Sorry, Vicky. Hello. I hope I'm posting my question in the correct place. Yes, you are. What are the first signs of hypergranulation on a tummy tuck wound? Is there anything you can do to avoid this happening after a tummy tuck? Is there a number of weeks post-op that you can feel safe that hypergranulation on your scar won't happen? If it does happen, what's the best thing initially to do for it? Thank you. Vicky, thank you. Very nice question. And I just to make the distinction between hypergranulation, is that overgranulation you're talking about, or hypertrophic scarring? And I'll tell you what I mean by those two things. So overgranulation is when you have a wound. So the idea of a tummy tuck is you close the wound with dissolvable sutures, and you take the dressings off after a week, and usually, hopefully, it's all pretty well healed, and you don't actually have a wound. So usually you can wash and shower straight away. But sometimes you get little bits that open up and don't heal up properly, as I said about the tightness and all that sort of stuff. So if you get a little bit that opens up and doesn't heal up properly, this is not just for tummy tucks, this is for any wound. If you have a bit of wound that's sort of red and you can see what's called granulation tissue, which is healing tissue, healing red tissue, sometimes you can get something called overgranulation. And the overgranulation is that red healing tissue healing too much, and it gets quite florid and it gets quite raised, and it actually gets raised above the level of the skin, and so it's like a mountain. The skin can't heal across, and that's called overgranulation. And then, so if that happens, there's stuff you can put on that overgranulation. I say stuff, it's like stuff that we as doctors use, like steroid, like terracortriol. People used to use silver nitrate on it, but there's stuff that you can put on it, usually creams and things you can put on that red, florid, overgranulating tissue to help dampen it down, and then let the skin heal across. So that's usually in the first week or two. If you get a wound bit open up, then that's something that happens early on, because that's usually when the wounds happen if you're going to get a wound. So that's overgranulation. I wonder if you're talking about hypertrophic scarring. So hypertrophic scarring is red. So the skin's healed, it heals fine, but then the scars go too much and they get quite red and raised and firm, and they can be itchy. And so that's, I think, what you're probably talking about. So you haven't got a wound, you don't need dressing or anything, but the scar's quite red and lumpy and raised. I think that's what you mean. So the first signs of hypertrophic scarring on a tummy tuck wound or any wound is hypertrophic scarring is increased in certain skin colors, so certain skin types. So Afro-Caribbean patients who've got a high risk of hypertrophic scarring. It's more common in or keloid, that's particularly keloid scarring, which is sort of like the end of the spectrum with hypertrophic scarring. It's common in certain areas, so the shoulder, the sternum. There are earlobes you can get it. So there's areas which are have got increased risk of hypertrophic scarring. And also if there's delayed healing, so if the wound does take a long time to heal, there's an increased risk of hypertrophic scarring. So the first signs of it are the scar starts to go red and thick. Now, to be honest with you, all scars are a bit red and thick to start off with. The first, couple of months, they are quite red and they feel a bit thick. So anything you can do to avoid this happening, if you know someone's got a high risk of getting hypertrophic scarring, and I've got a family history or what have you, I had a patient actually the other day who had previously had an operation and had a keloid scar on her abdomen, and then once came for a tummy tuck. Well, you have to counsel people very closely and say they've got a very high risk of getting another keloid scar, and they've got to decide whether it's right to have a tummy tuck or not. There's nothing you can do to make the keloid scar come back. To make this scar not keloid, because we just do that with everybody. So there's nothing you can do at the surgery or what have you to make it less likely to form a keloid scar or a hypertrophic scar. So you can't really avoid it. You can only treat it if it happens. So what you have to do is keep an eye on it. If it starts to go red, if it starts to go raised, keep a close eye with your doctor. Is there a number of weeks post-op that you feel safe that hypertrophic scarring or scar won't happen? I guess no, not really, but certainly if it's not happening in the first 3 to 6 months, I would say it's that's okay. It's less likely to happen after that, but the skin normally heals. The first couple of months it's a bit red and firm normally, and then it tends to soften after the first 3 to 6 months. But if it's not softening, if it's getting more red, if it's getting more raised, if it's itchy, if it's annoying, then that suggests it might be becoming hypertrophic. And there are things you can do for hypertrophic scarring. You can inject them with steroid, so different to the overgranulation where you put the steroid cream on. This is actually when you inject in. It can be a bit uncomfortable. You can massage them. And so, yeah, there are certain things you can do. Silicone dressings. There are things you can do to dampen down the scar and reduce the risking of keloid scarring and hypertrophic scarring. Probably the easiest thing is silicone dressings, which can come in as ointment, as a sheet. So putting silicone on the wound can help. If you are worried that it is becoming overgranulated, and that's something that we're doing now at the clinic, and I'm putting a page together on the website so you can actually buy it on the website. But you can buy it in Boots, I think, and just in the pharmacy, steroid silicone dressings. You can get it over the counter. So Vicky, I've got the so Sarah. So what else have we got? We got Sarah. We got Junie. We've got a question. Lots of questions going on. And we've also got some. What are we up to on that other one? Oh yeah, that tummy tuck. So where are we? What we got here? I have a mesh bladder sling in place for the last 4 years, and I'm considering having a tummy tuck. Would having a tummy tuck affect the mesh? That is anchored just above my groin on both sides. I've also had a hysterectomy, so I have a scar that is quite low and would be removed if I had a tummy tuck. I'm a bit scared the surgery will cut through the mesh. Will it? I don't think so. If you're worried, I would probably get your surgeon to talk to your urologist or gynecologist, whoever's done the mesh. The bladder sling should be intra-abdominal, should be inside your abdomen. That's where your bladder is, and it may well be anchored in the groin area, but it should be deep to the area that is being operated with a tummy tuck. Now, if you're worried, get your surgeon to talk to your urologist or gynecologist, whoever's dealing with the mesh, because they know exactly where the mesh is, and that they're going to be the best person to talk about that. But I would have thought that it would not be at risk, because the tummy tuck is a soft tissue. The tummy tuck is all superficial to the rectus fascia. The rectus fascia is the sort of covering of the bowel wall. You don't go into the bowel at all when you do a tummy tuck. I've also had a hysterectomy, so have a scar that is quite low and would be removed if I have a tummy. That's correct. You would have your hysterectomy scar would be removed, and your tummy tuck scar would be in a similar place to where your hysterectomy scar is, but longer. So yeah, I think that's okay, but I don't want to say 100%, because really you need to get your surgeon to talk to the to get your surgeon to talk to the urologist or the gynecologist. But great, yeah, good question. Thank you. And we also Vicky. So and Junie has said, if you have a revision to fleur-de-lis, can you just have vertical cut, or does the bottom have to be open? No, Junie, you can just have vertical cut. So yeah, in fact that would be complications will be less, because anytime you do two, anytime you have a T, then the risk of healing is worse, because on that sort of corner of the T, the blood supply is not quite so good. So if you've already had a fleur-de-lis and presumably it's all settled, the scarring's all softened and settled, but you feel that you've still got vertical excess, and you want to have just that vertical excess tightened and not the horizontal, then you could just have a vertical ellipse taken out and just have that vertical cut excised and tightened, and you leave the horizontal cut alone. So yeah, that's perfectly reasonable. Jade, should you be at your ideal weight before a tummy tuck? If not losing weight after a tummy tuck, will that affect the result in a negative way, or can it just enhance what you already have? Very good question, Jade. It's such a good question, Jade. I suggest you ask it 3 times. That is excellent. So Jade, that I would have asked that thrice if I was you too. That is a very good question. Jade, yes, you should be at your ideal weight before a tummy tuck. It will not just enhance what you already have if you lose weight afterwards. it will make you have potentially a worse result. The tummy tuck is there to tighten the skin. That's the real point of a tummy tuck. It's not really to remove the fat. You do remove fat when you do a tummy tuck, but it's you can remove fat with liposuction, you can remove fat with weight loss. The problem that the reason people need a tummy tuck is two reasons. One, pregnancy, and two, weight loss. So weight loss is a very common reason to need a tummy tuck. Now, weight loss, you've lost the weight. You don't need to remove any more fat. In fact, if you remove more fat, if you lose more weight, it often gets worse. The abdominal apron gets worse when you lose more weight. And some people who've had a significant weight loss, have a huge abdominal apron, actually want to put some weight on to make themselves feel better because they're filling up the skin. But if you're going to have a tummy tuck, you need to lose your weight first, because the more weight you lose, the tighter we can get it when we do the tummy tuck. We want to make it as tight as possible when we do the tummy tuck. And the more weight you lose, the more redundant skin you had. You might feel that you look worse. You'll get a better result from the surgery because you will be able to get it tighter. So when we do the tummy tuck, we make it as tight as we possibly can. If then you go and lose weight, you could be left with redundant skin. Now, it depends on how much weight you're going to lose, but potentially you could be left with redundant skin after losing weight from a tummy tuck, following a tummy tuck. So you've got to be a bit careful in doing that, and you've really got to try and lose the weight first. Easier said than done, I know, but if you want to get the best result, lose it first. It will not enhance what you already have. It could potentially affect it in a negative way. So that is a very good question, Jade, and I'm very glad you answered it. Junie, can't see you behind that big question. Can't see you behind that big question. What big question? Oh, can't see you behind that big question. I get it. Sorry. Like that. Hello, I'm over here. Got it. Got it. Yeah, sorry. Right. Okay. Didn't mean to. Jade, I think it's good. So Jade, you've said sorry, didn't mean to repost that many times, and you've said that twice as well. So you've reposted your apology for reposting it twice. So so it's good. Jade, don't worry. You know what I would say? You know what I'm going to say here? I am going to say, oh goodness me, where's the bit gone? Well, I could say it verbally, but I'm not going to. I'm not going to say it verbally because I've got technology that can say it. Okay, so I'm not going to say it. I'm going to show it. Okay, please comment and share. I do say please comment and share. Now, it may be the same comment that you're doing repeatedly, but still it counts as a comment, Jade. So, you know, you've reposted your question 3 times and you've reposted your apology twice. That's 5 comments, Jade. So you are doing well on the comments. So keep it up. So please comment and share. Feel free to comment different things every time, or just comment the same thing time and time again. It's absolutely fine, but it is good to, in fact, Jade, you got 5 comments under your belt already. And look at Vicky. One massive comment, Vicky. You could have commented that in a couple. You could have made that a couple of comments easily. Come on, Vicky, get your comments in. 1 comment. Come on. Jade's got 5. So your entertainment. This is the entertainment. This is an entertaining show. You know, you didn't expect education, did you? What we're doing now is we're going to get back to the. I think I've done what I've said I was going to do there. I think I've got reason to believe I've answered the questions there. So I'm going back here to this question. The BodyTite. We did the BodyTite one, didn't we? Here we go. We're on this one now. Cracking along. I've had a breast reduction years ago, but have put on weight, obviously aged, and would like another breast reduction and uplift. Is that possible? And also, lots of ends in this, and also my nipples, I know it says nappies, but it means nipples. Nipples are very light in colour and scared and not a nice shape. Is it possible to have them tattooed to a slightly darker colour and shaped to a round, proper shape? So, yes, so this is saying, can I have a second breast reduction? Yes, you can have a second breast reduction. And I've said to you, haven't I, well, you need the op note, and you've told me who did the surgery. So, yes, you can have a second breast reduction, and it's not uncommon to many years ago have a breast reduction. And then over the years, what I normally say with a breast reduction and a breast lift, both of them tighten the skin and bring it up into your breast into a better position, but it just resets the clock. It doesn't protect you from the future, so it makes your breasts a better shape than they were, and it resets it to a better place. But then over time, gravity acts on them, so they will still settle again. Your body doesn't say, look, she's paid thousands of pounds to have a breast put right, for goodness sake, don't make them droop, make everything else droop. It doesn't do that. It makes everything else um, droops. So you can need another breast reduction after having one breast reduction. So that is not an uncommon thing, but what you need to do when you do a breast reduction, you isolate the nipple. You isolate the nipple on the stalk, and you can isolate it in all sorts of pedicles: superiorly, inferiorly, laterally, bilaterally. You can use it, you can have a vertical bipedicle, a horizontal bipedicle, all different, any sort of way around the compass, really. You can have the nipple sort of staying attached when it gets sort of swung up into the higher position. And so when you do another breast reduction, you aim to use the same pedicle. So ideally, you really need to know what pedicle was used first time. So what you really need to know is your surgeon needs to do, your current surgeon. Well, ideally see the same surgeon, but I think it was many years ago, was it? Years ago, yeah. So if you see the same surgeon, fine, he should know what he was doing then, or he should have your op note. If you are seeing a different surgeon, then your surgeon should be able to get the op note from the original surgeon slash hospital. So if you know the surgeon, you can approach the surgeon. If you know the hospital, they've all got op notes and records. So, but it is nice or important to know the original pedicle that was used in order to do another breast reduction to make that nipple safer. So because the risks are higher when you do a second one, because you're dealing with scar, and you don't want to base that nipple on scar, because it's more likely to have blood supply problems, nerve supply problems to that nipple. You may have had blood supply, because you say your nipples are very light in color. That sometimes means there was. But anyway, so your nipples are light in color and not a nice shape. Is it possible to have them tattooed? Yes, it is, to a slightly darker color and to a round, proper shape. Yeah, yeah. First thing I say, if you're having another breast reduction, then your nipples, or your areolas, really is what you're talking about. The nipples, the sort of bit that sticks out in the middle. So we're talking about the areola, the pigmented bit around the outside. That will be redone, and so it might be made rounder second time round. But we have a thing in theatre to cut things exactly round, and when we cut the areola, we always make it absolutely round. But when you see people in the clinic post-op, they're never round. They always go oblongy and funny shapes. They're never round. Now the good thing is that most people who haven't had surgery knows, unoperated on areolas aren't round, so that in a way is good. But yeah, they're never around. I was going to say something else then, but then they're never around. They always end up, not round. But it is natural to not have them round, although we do try and cut them round. But if you're not happy with the shape, then yeah, I say if you're having another breast reduction, it would be redone. But if you want them to be tattooed, that's a perfectly reasonable thing to do. When people have breast cancer, they often have the nipple and the areola removed, and it's a standard way to reconstruct the areola by tattooing it. So there are people out there who are experts in the tattooing of the nipple and the areola. And so it's something that definitely can be done. It often needs to be repeated, because sometimes the tattoo fades a bit to get the right color. It's a bit of an art, but it's a very established and common procedure for tattooing the nipple, and there are people out there who do it, who specialize in it. And we know someone. If you want to contact him, if you want me to tell you who it is, just contact us, and we'll hook you up, put you in touch. Bulge in tummy of the seroma. As a keen watcher of your fantastic Facebook Live sessions, their words, not mine, I wondered if you'd be so kind as to give me some advice on my TT. Happy for you to answer live on Tuesday. Well, just as well, because I am doing, as it may help others. I had my TT, tummy tuck, 5 months ago, after losing 7 stone, I developed a small seroma which was drained once and has now gone. I have, however, been left with a small bulge which does bother me. It's quite soft and I can pinch it, but it's not watery. I did have lipo on my tummy at the same time. I feel that your tummy should be flat after a TT, but my question is, am I being too fussy stroke critical? Do you think I may need to ask my surgeon for a small revision? I don't have unrealistic expectations, and I'm aware that after large weight loss, doing a tummy TT does mean the surgeon can only give you the best result with what you give them to work with. So would really appreciate your opinion before I send pics to my surgeon. I had mine done in Prague. I really don't want to offend them by saying I'm unhappy with it if I'm being too fussy. Pics below. When I look in the mirror, I can't see the bulge so much, but when I look down at myself, it's then I can really see it. So sent a few pics. Yes, you have sent a few pics, and I've seen a few pics. And thank you very much for that nice question and those pictures. I have seen them and reviewed your photographs. So it's very interesting. This raises an interesting concept of cosmetic surgery. The concept of cosmetic surgery is that the outcomes of cosmetic surgery are very much driven by the patients. But despite what you might see or read in the media, complication rate is very low with cosmetic surgery. Infections, wounds opening up, talking about those sorts of things. The revision surgery is very low, and so the most important and the biggest outcome measure, in my view, is patient satisfaction. So you know whether you've done a good job if you've got a satisfied patient or not. In other types of surgery, you know whether you've done a good job if the blood pressure responds, or if the cancer's been completely removed, or if they don't have to get up at night to wee, or if there's some slightly more objective measures. The outcome of cosmetic surgery is very subjective. And I've looked at your photos and I think you've got a nice result. To be honest with you, I think you've got a nice result. It's hard with photos though. And this bulge you're talking about might be more obvious in real life, and it might be more obvious when you look at certain angles. But I do think you've got a nice result. I think it's healed nicely and it looks like a good result. But you're not happy, you've got a bulge and you are wondering if something can be done about it. My view is that I think any good surgeon would want to know what your concerns are. And you've said here, what have you said? Something about you're worried about them thinking you're fussy. Worried about being fussy, and I might being too fussy and critical. I think most surgeons will want to know what patients feel about their outcome, and wouldn't want someone to say that they're happy with their outcome and then to go on, Facebook and say, well, you know what, it's a bit of a bulge. I'm not that happy with it really because there's a bulge and it's a bit this and that. You actually, I'd rather people said to me, there's a bit of a bulge. I may or may not to be able to do anything about it, but at least give your surgeon a chance to say, oh, that's really easy to fix. I'll fix that, no problem at all. Because then you're going to go away and say, crikey, that guy is fantastic. Because I had a bit of a bulge. You could hardly see it. And he fixed it with no questions asked. And he was brilliant. And now I've got a perfect result and I'm so happy and I love it. So we all want people to be like that. We want people to be like, oh, they're fantastic. I love them. And they've done a really good job. And I would say, look, you've got to give them a chance to him or her. I don't know, whatever. But you've got to give your surgeon a chance because it might be something that could be fixed relatively easily. And your job is to say what you feel about the result, whether you like it, whether you don't, what you don't like about it, what you do like about it. And our job as surgeons is to say to you what can be done about that. And sometimes we say, look, you know what, I don't think there's anything can be done about it, or there is something can be done about it, but there are risks and downsides with it. I don't think it's worth the risks, or at least to explain to you what the risks are so you can balance the risks, to make a decision between the two of us as to whether it's right for you to have revision surgery. So it's fine to express your opinion. It may be that nothing could be done, or at least if you did something, there's risks of causing other problems, which you might be even more unhappy with, and might give you a worse result. So you might think, oh, on balance, actually, I'd rather not take that risk on. So it is something that you need to talk to your surgeon about, and I think you would be doing them a disservice by not talking to them about it. I think they would want to hear about your concerns, and they would, you know, examine you in person. You can't beat an in-person examination. You know, it's always hard to show on the photos, to feel if there's a lump. Is there some? Oh, look, there's a lump there. I might be able to, you know, make a little incision and take that lump out. I don't know. And yeah, so don't feel bad. You know, don't feel bad. You've you know paid a lot of money to have the surgery. The surgeon's trained for years to do the surgery and wants to make everyone happy. And if he's or she's not, you know, made you completely happy, he or she would probably want to make you very happy. So yeah, go for it. As I say, I think you got a lovely result. To be honest with you, I think it looks great, but there may be something that can be done. Sorry, I've been neglecting my comments. Agree with the comments. Interesting. Can you have? Oh, look, here we go. Here we go. Here we go. Pointy head. Yeah, it doesn't look so pointy today, actually. So yeah, good luck with that, and I respect you, and I hope that you get, you know, you're able to talk to your surgeon. And it's a very nice question, that, because you're worried about upsetting your surgeon, but I think you'd upset them more by not asking the question, really. So I really good luck with that. I hope they can help you, look after you. Rachel back in now. Rachel is someone who asks different comments, you know, as opposed to Jade, who is more of a sort of a repeat commenter. But it all works. It all works. Whatever. If you want to ask different comments, if you want to ask Zoe, if I could thumbs that up, I would, but I can't on this thing. It all works. Different comments, repeat comments. I'll take all the comments I can get. So, Rachel, can you have your areoli revised with local anesthetic? Yes, Rachel. Yes. I mean, it's not a great area for local. Let's be honest. Let's be, you know, person to person. It's a sensitive area. You know, the areola is a sensitive area, and it's not a great place to have local anesthetic. It might bring a tear to your eye, um, um, but it is if it's just something to your areola, if the shape's not right, if they're too big or they're not round or whatever, you're having some. To be honest with you, I think is the best way to do it. I saw someone in the clinic last week who needs an areola revised. We spoke to about GA and local. I pretty much always do it under a local. To be honest, I pretty much always do it under local. GAs are very safe, and if you do it under a GA, it's a day case. You can have it as a day case. You go home the same day, so it's not a massive thing. But I would say a local safer and better, because you just walk straight out. As I say, the local going in does sting. It does bring a tear to your eye. You have to be prepared for that. But once it's in, you're fine. You just feel touch and movement. It can take quite a long time. It can take quite a long time to do the surgery, so you have to be prepared and sort of on board with everything. If you really don't want a local anesthetic, oh my god, I hate anesthetic, I don't want a general, fine, have a general, because you will, depending on what you're having done. But common things like an areola reduction, if you're having both areolas made smaller, hour and a half, maybe 2 hours lying there. We will chat to you and stuff, but if you're really not enjoying, because you do feel movement. That's the thing about local anesthetic. You do know that something's happening. You hear noises and you feel movement and stuff like that. Don't feel anything sharp. You do feel movement. So, if you really like, oh, I don't fancy that, then it can be done under a general. But I would say it's better to have it under a local, personally. But it's something, personal thing. It definitely can be done under a local. Jade's back in. Jade, sixth comment, liking it. Just one time, is it? You're not repeating that one. Okay. Let's try again. What determines where a breast implant is placed? The things that determine it mainly really is your anatomy, I would say. So what you're alluding to there, I think, is whether it's placed in front or behind the muscle. So that's a big area, and broadly speaking, it's in front of and behind the muscle. There are the variations of putting it in front of and the variations of putting it behind of, but that's the broad thing, which position in terms of the muscle. And there's good and bad about both. It's not like one's better. If someone tells you one's better, well, one might be better for you, or they might, I normally say, look, these are the pros and cons, and I'll say this, I think probably this one will be best for you. But you might say, yeah, no, I don't want that one, I want the other one. But pros and cons. And the good thing about putting it under the muscle is if you haven't got much cover, as I say, the muscle's a pec major muscle, and your pec goes across like that, so it only ever covers the top part of the implant. It only covers this part of the implant, the muscle. And if you're very skinny, if your ribs are, if your ribs are visible, if you can see your ribs, if you can, then that's when it really comes into going under the muscle. What we do is we do things a pinch test. Basically, is looking at how much soft tissue you've got in the upper pole of your breast. And if you're very bony, if you can see your ribs, then I would say to you, look, if I can see your ribs, I'll be able to see the implant. How can I hide the implant if you can't hide your ribs? Excuse me. So, you know, if you're very skinny, then under the muscle is good because it hides the implant in the upper pole. You might say, well, why doesn't everyone have it under the muscle? If it, why doesn't everyone have it under the muscle if it's going to hide the implant in the upper pole? Surely that's a good thing. Yes, it is a good thing. But there are bad things with putting it under the muscle. The bad things about putting it under the muscle, it does hurt a bit more, bleeds a bit more, recovery is a little bit slower. But the main things about putting it under the muscle, sometimes the muscle can hold it up, implant high, sometimes the muscle can hold the implant wide. So if you see someone with a very wide cleavage, that's usually if they put it under the muscle and they haven't released the muscle enough. So that's a risk. And sometimes you can get animation deformities, which means when you exercise, the breast can move because the implant's underneath the muscle. So there are risks with putting it under the muscle. But there are good things about putting it under the muscle. So you have to sort of balance those risks. Now, those things like sitting high, sitting wide, and animation deformities are risks. It's not like they're going to happen, but they're risks. And the risks you don't get when you put it on top of the muscle. As I say, there are different nuances. So when you put it onto the top of the muscle, you can do it subfascial, which is sort of an extra layer of cover over the muscle called the fascia. It's a white layer, so you can put it under that layer. And similarly, when you put it under the muscle, there are different plane. You can use something called a dual plane, and there are different types of dual plane. People sometimes come to the clinic and talk about that sort of stuff, which, you know, we're happy to talk about, but to be honest, I wouldn't get into it too much. It's quite technical and it doesn't really matter, I wouldn't say to you. I think the main thing from your concern is it over or under, and there are pros and cons of both of them, and it's not like one's better. If one was better, we wouldn't do it the other way, but it depends on your anatomy. It does depend a little bit on the type of implant you're having, but it's mainly your anatomy. That's the main thing that determines that. Caroline, good to see you. Big up yourself. I'm not sure what that emoji is. Is it clapping hands? Excellent. Round of applause. That's what we need. How will I look after surgery? A big one. This is my last one, by the way, guys. I'm gonna give you fair warn. This is my last pre programmed, you know, pre-asked question type thing. So happy to take any questions live as ever, but if you, this is my last one. Also, how do you give, oh no, this is the question. How do you give clients an idea of how they will look after surgery? I mean, it's a massive question, this one. This is a patient having breast implants. It's difficult. I'm sorry to say it's difficult. I think a lot of people think it's a lot more sort of precise than it is. And there's loads of different things you can do. You've got 3D imaging where you can take a photo of yourself and morph the photo and, you know, show the photo what it would look like with implants. It would, to me, else you can morph anything, you know, nose job and breast implants, breast lift. You can morph the picture to make it look like you've had implants and things. Peter, have you seen the one with the virtual? You put the goggles on, virtual reality, and you look at yourself. I mean, it's the bottom line is it's difficult, and there's no anytime there's lots of ways of doing something, there's no good way of doing something. So what we do is we do certainly for implants, we do a sort of a mix of things. We've got sizes in the clinic which we can put into the breast and give an idea about volume. That's just really volume, doesn't really tell you much about shape, but gives you an idea. If you don't want to be a C cup or a D cup, the sizes are a bit better because the size is like that's 250 cc's, and you say, yeah, that's the sort of volume I want. So it's a bit more specific than saying a C or a D cup, but it doesn't really talk about shape. The most important thing with implants is the width. So the width of your breast or your chest is set. So there'll be a certain group of implants that will fit your frame already. And then you look at the shape and profile, and we do that by looking at different before and after photos of people with different shapes and profiles to try and get an idea what sort of shape and what sort of profile of implant will give you the look that you want. But it is always difficult because you've got to add that shape and profile to the shape of your breast currently. So, you know, if you say, oh, my friend's got a moderate profile 250cc implant, can I have the same? Well, it might not look the same on you because your friend's frame might be different to yours. Your friend's breast shape might be different to yours. So it's difficult, and that is why we only charge for the initial consultation. And I always say to people, come back. You know, encourage you to come back time and time again. Go over it again. We'll talk about it to try and make sure you're absolutely comfortable with the implant choice. before going ahead with it, because two things I'd say. First of all, you have to be comfortable with it in your mind. Um, because if you are unhappy with the implant, if you have surgery, we say, oh look, we got this guarantee, warranty, we'll look after you and all this sort of thing, which we will. But if it's just purely the size of the implant you're not happy with, that's not covered. So if you're like, you know what, actually I don't like these 250s, can I have the 350s, that's not covered. So you've got to be sure about the implant choice before you have surgery, because if it's purely the size of the implants that you're not happy with, if they're not right, if they're sitting high, sitting wide, sitting low, if there's a problem with them, swollen up or anything like that, we will fix it, no problem at all. But if it's purely just, oh, actually, you know what, I changed my mind, I want the big ones, that's that's not covered, you have to pay. So that's number one thing. Number two thing is that it doesn't actually matter as much as you think. You have to get the implant sitting right. I would always say choosing your surgeon is probably more important than choosing your implant. Obviously, it's important to choose the right implant, but if you get an implant not sitting right, too high, too wide, too low, whatever, one's out here, the other's out there, it's not going to look right. Doesn't matter what implant it is. So that is crucial, but something that people don't really spend much time considering. It's not fair. They probably do spend a lot of time considering it, but I think people don't realize how important that is. They think, actually, should I have the 240s or the 260s? It often doesn't matter too much when it comes down to sort of one or two. There's millimeters difference in the size, and people get very invested in it and think, actually, I'm not sure which one to have. Actually, I have the 260s. Okay, as long as the width is right, as long as the profile's right, the difference in 240, 260, whatever, it's probably going to have a marginal effect, but the positioning of them is going to have a big effect. So that is more important than actually the actual implant itself. Zoe coming in last minute. Zoe, is fibroblast plasma lifting on upper eyelids as effective as blepharoplasty? Oh my God, Zoe, what are you doing to me? Fibroblast plasma lifting. What's that? What's fibroblast plasma lifting? I'm going to take a punt, Zoe, and think, is it one of those things where they spin down your blood and they separate? Is it like the last platelet derived things? Anyway, there's stuff when they inject it in and they say that it's, enhances collagen and what have you. So basically, Zoe, I'm going to come clean. I don't know what fibroblast plasma lifting on upper eyelids is, but I'm guessing it's some kind of non-surgical thing, perhaps using your own blood. Sometimes they do things with your own blood, and there is a big move away from doing surgery, and there's a lot of people looking for ways of doing things non-surgically to tighten skin. Blepharoplasty is the same as tummy tuck, is the same as facelift, it's the same as mastopexy in terms of it's tightening your skin. It's removing excess skin of your upper eyelid. And so there's lots of people out there trying to find other ways to tighten that skin rather than doing surgery. And it's a huge industry and a huge business, but surgery still exists. So the answer to your question, I don't know what fibroblast plasma lifting is, so I'm not in a good position here to answer your question. But in general terms, non-surgical stuff where you don't actually cut the skin out and give you a scar is less effective than surgical stuff. Surgical stuff can give predictable results, and blepharoplasty is one of those ones where the scar is hidden. It gives fantastic results predictably, but it's a surgical procedure. There's scar and there's risks and things like that. So I can understand people wanting non-surgical procedures because they've got less risks, less complications, and I totally understand that, but they're less of a result. So if it was as good a result, no one would do surgery. We don't want to make cuts and give potential for infections and scars and things if we don't have to. But blepharoplasty is a excellent operation. The scar is really hard to see, and it gives predictably good results. And non-surgical stuff is less predictable. So I would say look for someone who does fibroblast plasma lifting, look at some results and see what you think. Sometimes you can try the non-surgical stuff first, see how you go. No harm in that, only in that it's often very expensive, the non-surgical stuff, so that's a potential harm in it, but it's that's an option. Jade, thank you for answering your questions. 6 questions, excellent. 3 individual questions, but 6 comments in total. That's a good rate that anyone will be proud of. So I think I'm out of questions here. I'm very grateful to everyone for commenting and for participating. I will be back here on when we got. I should say I haven't said this before. This is all on a podcast, by the way. I've got a podcast every week comes out with my Facebook Live. It all goes on YouTube, and we are starting to do a vlog, which is what you were seeing when we started the shambolic. Actually, did I want that there? Don't know what I wanted there. The shambolic incident at the beginning that unfortunately you witnessed because it was a live thing. They were supposed to be in the background as part of the sort of behind the scenes vlog, but early days. So, yeah, thank you all. Look at that. Zoe thinks I'm a star. Thank you. Even though I don't know what fibroblast plasma lifting is, look at that. Still a star. Thanks, Zoe. Sorry, I didn't know what that was. I would say, Zoe, I don't do eyes. In my defense as well, I don't do eyes. Junie, everyone, we all want to make people happy. I think people have this impression that people, in Prague or whatever, overseas surgery, dodgy and all that sort of stuff. But I think surgeons all over the world, we all want to make people happy. I think I can speak for everybody in Turkey and Prague and goodness knows where. I think the surgeons are all trying to make people happy. I think one of the problems is it often gets into sort of these commercial enterprises that employ the surgeons, and then you get a commercial element to it that often the surgeon may not have control over, and so the surgeon is deemed to be unhelpful and stuff. But I think most surgeons are trying to make people happy and will go as far as they can to make people happy. Yeah, certainly I want to make clients or patients, whatever, happy. But yeah, Junie, excellent involvement tonight. Thank you very much for that, as always. Thank you all. I'm going to check myself out of here, and I will see you same time, same place, Tuesday night, 7 o'clock next week. Please feel free to keep the questions coming, because without the questions, it would be awkward. So I will be back next Tuesday. See you then. Bye.